Okay, so we're gonna get started now. So thank you again for joining me. And I mentioned my name's Ever. I'm a pulmonary critical care fellow. And the first part of the agenda, I'm gonna go over kind of a couple things. The first part, I'm gonna talk about professionalism. Spend a few minutes about that, just because I do feel like it's really crucial that you understand the importance of being a professional. Now that you're a physician, it took me a while to understand. I didn't have a job. And during before medical school, I had I worked here and there, but it wasn't like a full-time job. And it was just those certain things, skills that you learned on the job, you have to struggle to learn them. And I don't want you to struggle through to learn them. I want to tell you exactly what you need up front and be honest with you. And I'll go over that. And it's important. So this is important, and I want you to really focus on the professionalism segment that I'll talk about. I'm also gonna truly uh, teach you how to introduce yourself to everyone, the importance of really being a nice person, having good attitude with the team, how to be a team player. I'll walk you through wards, a typical schedule on wards, what it means to hand off, pre-round, how to master the EMR system, using templates, soap notes, and the importance of not memorizing things, how to be efficient, how to really be willing to accept mistakes and how to grow from that. Rounds, I'm going to tell you exactly what's important during rounds, how to present patients, the difference between presenting a patient who's coming in, who's a brand new patient for you, or a patient who's been there for many days, the difference between those presentations. And I'm also going to talk to you about having a system in place, the importance of having a system that is crucial to you being organized and being an efficient resident. Um, and then forming a differential. This is really where you shine. And I'm going to talk to you about how to really talk about a differential in a way that really makes sense, not just talking about the CBRS, and really just coming down to having a good clinical judgment on the patient, and having a really nice clean assessment and plan that makes sense. I'm also going to talk about the workup. How do you work up a patient? What's the management, and how do you present that information when you're presenting patients? And I'm also going to be followed that with examples as well. I'll talk about interpreting labs, CBCs, Chem 7, the basics basically, and then we'll continue making another sessions. I'll go over more details on that. I'll walk with you on interpreting chest X-rays, the bread and butter stuff. I'm a pulmonary critical care fellow, so there's a lot of details that I might tell you that you might not have to know, but you'll probably impress the residents after you listen to this. Um, and you'll probably know a lot more than most interns after this. I promise you that. Interpreting EKGs, I'm gonna walk you through how to interpret an EKG, the different steps, and all those things. Fluids, the importance of fluids, how to administer fluids, what type of fluids, crystalloids, colloids, all those things will be done in this lecture. And the amount of content, how much sodium it has, how much chloride, and why that's important. I'm going to talk to you about empiric antibiotics. How do you start antibiotics in general? What are they? What do they cover, etc. And lastly, I'm going to just show you how to be efficient during night flow, during cross cover, how to answer pages, how to multitask, and really the importance of taking breaks so that you enjoy residency. And at the end, I'm going to open it up for questions. But at any time that I'm talking, if you guys don't understand anything, please message, put any comments on the chat box. I'm willing to stop, read out your question so that people who can't be here are able to at least hear that question. And I'm sure they might have those same questions. So I want you to feel comfortable. You and I are on the same page. We're here to make the best of the time that we have. I'm in no rush to try to get all this done. I want to make sure that I'm here for you guys. So if you have any questions and you're like, hey, I'm going to sound dumb if I say this question, trust me, that's the point. I want you to realize that it's okay to sound dumb. No one cares. Trust me. All we care is that you actually understand things. So if you guys could comment saying that you're good, you're ready to go, we'll get started. Or if that sounds great, we'll get started. I know it's a lot, but I wanted to I wanted to really give you guys everything that I have with the time that we have. Okay. And I have an outline here. So if I keep referencing it back and forth, it's because I want to make sure that I'm organizing myself, my thoughts and everything. So let's talk about professionalism. This is where I'll write, and I apologize for my messy writing. I'm not a, I'm a physician after all. So let me see. Let's try the thin one. Oh man, this is terrible. Okay, this might not work. We'll see. Okay, let's see. Uh, So let's talk about profession, being a professional, professionalism, if I could spell it. Okay, okay, professionalism. So the most important thing is, is there's a couple things. I like to focus on being someone who has honor. So being a professional, professionals do not lie. Very important. Regardless of whether you feel like people are judging you and you feel like you should know this, and if you don't know it at the spot, don't make it up. If someone's asking you, hey, did you go see that patient and you just didn't have time, be honest. Say I didn't see that patient. Just own up to your your yourself. Basically, own up to anything. Don't make up lies. Don't say I did and when you didn't. Don't say I saw that lab when you didn't, etc. Be honest and trust me, people will tell if you're lying. So don't hide it. The other component is I want you to always show up early. Okay? Show up early. That means when you have to get there at 6:30, are you gonna get there at 6:30? No, you're gonna get there at 6:20. 6:20. You're gonna showing up early means not showing up on time. It actually means showing up before the time that you're supposed to get there. That's what a professional does. Professionals show up earlier than what they're asked to show up. Because typically, if they tell you to show up at 6:30 in your mind, you're like, I'm gonna show up at 6:30. Guess what? You're gonna show up at 6:35. It always happens. I'm telling you this because guess what happened? This guy would show up late. I'm learning, and I don't want you to learn this after people have told you repeatedly, you're showing up late, you're showing up late. Don't be that guy. Basically, don't be me. Always, always be ready. Always be ready, guys. Really important. What this means is when they tell you, hey, you're gonna be presenting a patient at 8:30, you guess what? You show up again early. You show up instead of 8:30, you show up at 8:25. That one I'll give you a little extra time, more time to round. You show up 5 minutes early, exactly where you're supposed to be. You're ready. You've reviewed the patient. And we'll talk about how to do all that and how to be efficient. But you're ready. You're ready to go. You have all the data in front of you, and you're not fumbling through your paperwork. Okay. The fourth thing is, I want you to do all the above often, not once, not twice, not every Friday 13, literally every day. Be con- be consistent, I should say, not constant. You know what I mean. Don't be constant. Be consistent. Okay? I want you to be consistent because consistency will build habits and consistency will make it easier for you to just do things without thinking about it. But it takes time. So if you're not an early person, if you always show up late, it's gonna be harder, but it's not gonna it's you could always change. You could always get better. And obviously it's gonna take time and it's okay. Number five is take feedback like a boss. So I want you to listen when you're getting feedback. Hey, they pull you after, let's say, your first month. You're not doing so well after your first week. Instead of defending yourself and saying, oh, you know what, I actually did know the answer. It's just that It doesn't matter. Just listen instead of saying, instead of responding. The most important skill is listening in residency, not responding, not showing how much you know, listening. Listen, listen, listen. You'll have more respect from your peers if you actually listen first before responding. I promise you. Take feedback, um, and not only take feedback, but actually use that feedback and get better. Take feedback and act. Okay. 6. This one is kind of a simple one. I'll skip it. Is actually I'll just say it because I think it's important. Be humble and nice. This is something that I probably don't have to tell you guys, since I'm sure you guys are good people, but you'll be surprised what kind of people are in medicine. Uh, that's a D. Don't be overconfident. Okay. In the beginning of training, you're you have a curve, right? You have training here. You have ego here, right? You're an intern now. Your ego's like right here. Your ego's so bad, so low, and then it starts going up. It starts going up. You feel like you know your stuff. You feel like you know your stuff, and then you become a second year. It goes drops down again, and then you're finally okay. Finally, I'm a second year, third year. I'm good. I'm good. You become an attending, then drops down. That's okay. This is not what I want you to do. Actually, ego is not a right word. Just confidence, basically. Confidence. Confidence, right? Training. Don't do this. Ego's already here. It drops a little bit, but here, like you need this to learn. You need this has to be low. This should be negative. Don't be that. It's okay to do that. So it takes time to grow your confidence, and that's okay. So be humble. You don't know anything, and that's okay. Ask for help, and if you're nice, people will help you. Ask for help. Ask for help. Okay. Anytime. Not on Mondays and Wednesdays and Fridays only, not on the weekends because people are less busy. Anytime. And if you feel like you're working with a senior who is not helping you, talk to your chiefs. In the end of the day, you're there to train and they're there to help you. And if you feel like you can't have your questions answered, it's guess what? It's affecting patients, not you. You're healthy. Yeah, it's affecting your learning too, but it's affecting patients primarily. What if you do something wrong and he or she should have told you not to? So speak up and talk to your chiefs. Okay. Be willing. So the other one is be willing to help anyone, including your non-physician staff. Help everyone. Okay. So what I mean by that is if the nurses are like doing something and it's not really physician stuff, like to help, don't just walk out if they're moving someone or they're moving a patient. And if you have extra time, try to help, it'll pay off. They'll do favors for you too. And then own up to your mistakes. Okay. No matter how small. Okay. So really the big thing is you need to own up to your mistakes. It goes a long way. It shows character, and it really shows that you do care about your growth, right? That's what they want to see. Residency programs just want to work with someone who's willing to learn from them, who's there to learn, is motivated, understands that they don't know things right now, but they're only going to get better. Okay. People could People are okay with you not knowing things. They're not okay with you having a bad attitude or not being a good professional. Um, with that being said, again, I'm reiterating a lot, but there's a reason why. Don't blame anyone but yourself. Yourself. This is your responsibility. If you're not learning, ask yourself why. If you're having a bad day, why? If your girlfriend broke up with you, why? In the end of the day, don't don't blame things on other people. Your happiness is really your own responsibility, not no one else's. And then also with that being said, please, it's never the patient's fault. Never patient's fault. Don't say that at all. And there's a reason why. There's things that are gonna happen. Patient was this, they didn't want to follow the advice or whatever. There's a reason why they didn't follow your advice. Maybe you didn't explain it well. Maybe, there's a reason why they eat in the morning or they had water. You didn't explain things well, even though they were supposed to be MPO, etc. Understand why. Be responsible for your own actions and follow through. So follow through. If you're gonna say that you're gonna do something, actually do it. Don't forget about what you're gonna say and just say it just to say it. Actually do things. You're gonna be remembered as someone who gets things done that way. Um, prioritize. Learn to prioritize. What's important? What is important versus not? Do the most important thing. Eliminate non-essentials. Okay? Don't do too much. Focus, focus. I want you to focus on things. Don't do 20 million things. And I'll tell you why in the next couple of things. Um, next couple of topics. Then be okay with not knowing. The most important thing is really that you're a learner, right? You're here to learn. So be okay not knowing. It's okay to not know. That shows you reflect. That shows that you have introspect. You're able to reflect on your own kind of knowledge, and that's really important. Don't. But the most important thing is don't accept stagnation. Be curious. I want you to be curious. Ask why if you don't know, right? So you really have to be curious and be asking questions like, why is it that this is happening, or and I want you to be curious about those kind of problems. And the way that I did it is I would keep a check. I would have questions that I would ask myself, and throughout rounds, and I would keep a tab of the questions that I had. And at the end of the day, I'll try to answer them by looking on Google or using other resources. Okay. So now we're getting into that's like professionalism stuff. I had to say this because I think honestly, this is probably more important than what I'm about to say, but I understand that you also want medical content stuff. So this is the next couple things. Will be medical content now. Does anybody have any questions about this professionalism segment? Okay, if someone says, can someone say no, and then we'll move on? Okay, so the next part is really most important thing is whether you start in ICU or in the wards. You're the new person, right? No one knows who you are. So you want you to go in there, have a attitude, have a great attitude. Don't. It's okay to be nervous. Everybody's nervous the first day. It's totally fine. I would recommend showing up early and being ready. Leave your emotions at the door if you can. Obviously, if things are not going well at home, I understand. Speak to someone, get the help you need, but don't drag anybody in your own drama. Just go there and you're going to do business, make friends, and of course, enjoy your training. But at the end of the day, I want you to just go in there with a fresh slate every time. And so be open to talking to everybody, the nurses, I mean, I talk to anybody, the housemaids, cleaning lady, everything. Um, be friends with everybody. You'll be basically the place that you'll be at will be your home for the next couple of years. So it's better to just kind of get acquainted with everybody early. The biggest thing is planning. When you start any type of new rotation, I want to make sure that you're sleeping early, planning early, meaning is your medical record account set up? Do you know where your templates are? Like, if you guys don't know what templates are, sometimes typically you're obviously writing notes as interns. You got to make sure you're writing your progress notes, discharge notes, uh, HMP notes, obviously admission notes, those are HMP notes. Talk to someone who's a second year and see if you can borrow their templates. There's Epic, there's a way for you to also steal their templates technically, but without even asking, you're able to just kind of grab onto it. Sure, someone could teach you how to do that. There's many ways of getting templates. And templates, you need templates. Everybody uses templates to be able to have notes done pretty quickly and not spend their time making it from scratch. So kind of find a template that you like and keep using it. And then the other thing, obviously, is wake up early. Give yourself some time to relax, do whatever you can to get in the right mindset before you start work. Make it a habit early, and it'll definitely pay off later on. Um, okay, so let's talk about wards. Who here is starting in wards as their first rotation? And what sort of? I mean, I already have certain things that I was going to talk about in this segment for wards. But if you guys tell me if you're starting in wards, and then what are you more nervous about, and what are the questions you have about wards? You're starting VA wards, okay? Wards, general surgery, wards is second rotation, VA wards, okay. Two people are starting ICU, okay. So someone wasn't given their schedule yet, okay. That's fine. Most likely, yeah, it's okay if you haven't been given your schedule yet. Hopefully soon. So question, how to quickly round and finish notes in the morning. General surgery is my first one. Okay, cool. So yeah, this is definitely helpful for all of you guys, regardless of whether you're starting wards or not. You're gonna do it eventually. If you're starting ICU, this is also gonna be helpful, but I'm gonna focus on ICU tomorrow. I'm gonna have another session for you guys, and I'll talk about ICU stuff. It'll be a lot of ICU bread and butter, like vent management, all these things, pressors, for you guys. So let's talk about wards. So wards typical schedule. So let's see. So we have wards. Okay. So usually, you go in at depending on the program. My program we started at 6:30 a.m. and that would be like you get handoffs. What is that? Handoff is basically where they tell you about overnight events. So basically, tell you the tasks that got done overnight, slash cross cover stuff. So most programs have a night intern and a night resident doing admissions at nights, and then they're also doing cross cover. Any tasks that the day team asks them to do overnight, they'll follow through. And the handoff is basically telling you what happened overnight. Was there anybody who got really critically ill? Was there any events that happened? This is what I did. The tasks that you told me to do, I got them done. And then you get also admissions. So they tell you about overnight admissions. Okay. So then, around you basically start, say if you round, maybe it takes 30 minutes, 10 minutes, 15 minutes. So maybe 6:45 a.m. is really when you start pre-rounding. And then pre-rounding, really the big thing is what I want you to do is important is really get acquainted. So that's what this is like a day before. Day before, this is gonna maximize your time during pre-rounds. Day before, read about your patients, uh, right? Um, kind of read about your patients, the story, the uh, the problems. What problems do the patients have? So you have an idea, and then also be familiar with um, with navigating EMR, the medical electronic medical record. So I want to really everybody has. I had Epic, and Epic was pretty good, but everybody has different systems. The VA has like the worst one. So if you're in the VA, your first day is going to be really bad. Just kind of go in knowing that, and it's okay. My day was like terrible. Half the time I was like stressing out because I couldn't even navigate the VA system. So I have actually, if you could message me, I made a VA, if I still have it, a VA for other residents in my program who were at the VA. I ended up making a cheat sheet on how to navigate the VA medical record system. So if you're interested, message me and I'll give it to you. Okay. Hopefully it helps. But regardless, even if you don't, I think you'll be okay. So that's really pre-rounding. But the goal, what is the goal about pre-round? What's the goal of pre-rounding? Is really to acquire data, right? So data. So whether it's objective, meaning labs, well, vitals, technically vitals first, labs, images, micro, right? And then also subjective, right? How was the patient doing? Symptoms, better, same, worse, or new symptoms. Okay. So really the goal is for you to go in, get your data. So the way that I function is this. So assuming that you have your templates ready, assuming that you have everything, everybody has their own style. Um, as an intern, you're probably going to print out the last progress note. Everybody has their own way of doing it. In the beginning, it's a lot of data for you to really have to memorize everything. So you're going to print, um, so you're going to, the way that I do it is you first go to EMR, use the template. So it's typically it's like dot progress note, depending on what template you use, and it'll give you like the progress note. And then there's hyperlinks. Basically, those get auto-filled. So essentially, this will give you the vitals, this will give you the labs, and then you could print it and you can make it, there's maybe it might be 4 pages. You could do small, I forgot the terminology of it, but there's ways of instead of printing 4 pages, shrinking those 4 pages into 1 page. So 1 page, it'll be like squared. So it'll be like you have, you know, the maybe some objective here, labs here, vitals here, I think, um, image data here, and then this is like your assessment and plan of what it was. You could flip that, flip it over, flip it over. I don't even know how to draw. Flip it. In the back, you could write other data, other things that you want, like tasks to do, like tasks for that day. Alternatively, if you feel like you know your patients really well and you don't need to print everything, this is more of a second year level thing. I don't expect you to do this already. I think it's perfectly fine to print everything out and at least have it so you can reference it. Is you basically just print the list. So what you have is you have a list here right? It has a patient's name here, all these things, and then it has other things here. You could decide to do what you want with it. Each line is one patient. And then you're able to kind of next to it draw this. This is a fishbone of your labs. So you could do it here and then like here. So you're able to reference the lab right away. Um, Here you have the white blood count, hemoglobin, platelet, and then here you have sodium, bicarb, chloride. Sorry, this is potassium, not bicarb. Potassium, chloride. This is the bicarb. Okay, bicarb. This is BUN. This is creatinine. This is the glucose. Okay, so at least it's organized. So I have a question. I'll stop here and see what people have. I have an issue while pre-rounding where I find myself stuck in patient's room much longer than I like, 10 minutes or more, and only with certain patients. I've seen seniors cut off the interaction, but I haven't really learned how to do this while maintaining patient-doctor relationship. That's a good question, and we'll go over that in a bit. Okay. So I think the most important thing is, is every patient, right? You're really learning a lot. You don't realize. Number one is you you're learning about your patients, learning about patients. Everybody has a primary diagnosis. Why are they being admitted? And then that's followed by chronic problems, which trust me, if you're doing internal medicine, there'll be a lot. But you really want to focus on this. What's the primary diagnosis? And am I how how am I evaluating if it is getting better or not? So really, the question is, how am I evaluating? The whole point of pre-round is for you to go in there and have an idea of. I don't want you to go in there and not have an idea what you're trying to do. So, for instance, someone who has congestive heart failure, you're not going to go in there and talk to them about other things. You want to go in there, have a direct conversation. How's your shortness of breath? Are you making good urine? You check your urine output. You check labs, and we'll go over what labs you want to look at. That would signify good things. You check their oxygen requirements. Is that going down? Is that getting better? Basically, are they able to lay flat now? Are they not? Um, Things like that. Someone with sepsis, you're monitoring their sepsis. Are they having fevers overnight? Is the white count going up, etc. So, okay, so basically, you look at labs, you look at micro images, symptoms. This is all tell you if things are moving in the right direction or not, right? Obviously, vitals too. Sorry, vitals, labs, micro images, symptoms. So this will really tell you how things are going. And then basically the whole point of, and how do you put all this together? How do I put all this together in a nice form so that it's like a little present for the attending? It's called SOAP, subjective, objective, assessment, and plan. For instance, you tell them about your one-liner, obviously one-liner here. Who is this patient? Who is this patient? Okay, now I know who this patient is. Okay, before we go to objective, overnight events. Now you could say patient either had some overnight events or they didn't. Um, for instance, if they had AFib with RVR, talk about that. If they became hypotensive, talk about that. If they didn't give them medications because of X, Y, and Z, talk about that. Or if they didn't have any episodes, say no acute events overnight, and then just start from your SOAP. This morning, patients said this, that there's symptoms X, Y, and Z. Objective data shows, or you could say vitals pertinent for. You don't have to read everything out. You could ask the attending, do you want me to just tell you what the pertinent labs were? And he's like, yeah, that's fine. Or you could say, do you want me to, or basically if things are normal, just say, without a febrile heart rate within 80s to 90s, sinus rhythm, blood pressure. If they're hypertensive, say hypertensive. They're hypotensive, say that. Otherwise, say blood pressure in the 120s or whatever. I have to go back a little bit. Just report. Don't say hypotensive. Don't say hypertensive. Just say the number. Then your assessment plan, you will say what those mean essentially. So I kind of had to correct myself there. That's objective is the vitals, physical exam. So vitals, followed by physical exam, followed by labs, followed by imaging, followed by micro. If you have any of these, you don't have to have it. So you could say vitals were remarkable for this, physical exam. You sometimes you like attendings like you to say everything, and I think it's important for you as an intern to like read everything out, even if it's normal, just because you're getting in the habit of reporting things. And throughout the year, you'll just say what's more pertinent. Labs, there's an art to how to report labs. Basically, what I want to know is for labs. So let's say you have, this is the way I like to report my labs, the way that I like to keep my labs. So let's say I patient's white count is 15,000. I write down like parentheses to remind me that yesterday it was 22. Hemoglobin now it's 12, but yesterday was like 7, let's just say, and he got transfused, right? So it's like, I'm just making an example. So it reminds me that yesterday was 7, now it's 12. Something obviously happened there, right? Platelets, 300. Yesterday was also like normal, but I just say it. Labs, same idea, here. I'm not gonna write it all over again, but essentially just to remind you, sodium goes here, potassium goes here, chloride here, bicarb goes here, right? BUN here, creatinine here, and glucose here, right? And then you can talk about INR depending on what the patients are, LFTs. We don't get LFTs always. We usually Chem 7 and Chem 10. We don't really do often, mostly Chem 7, just this. And then CBC we get daily. LFTs only if patients are coming in with LFT problems that you could trend it if you wanted to. So the way that I would say is, labs, CBC showed a white count of 15. Yesterday was 22. Hemoglobin, either if it's stable or not. Let's say it was 12. Yesterday was 10 or 12. You could say, you know, hemoglobin 12. Yesterday 10, and then platelet whatever. Kind of those things to kind of have an idea. If someone has another important point, if someone has CKD or end stage renal disease, their labs are going to be really out of whack. It doesn't matter. You could just say patient with end stage renal disease, end stage renal labs. You don't have to say creatinine of 8.0. I mean, it's going to be high. And then we'll talk about specifically what makes AKI and what doesn't, and the definition for that as well. So really the most important thing that I want you guys to understand is there's a lot of data, right? There's a lot of data, but don't memorize. You don't have to memorize. The point is not to memorize. Don't memorize. You're going to forget things regardless. It doesn't matter how good your memory is, you're going to forget things. Instead, have a system. Have a system down. That's the thing that's going to be more important, is for you to have a system in which you know exactly where the data is. Know where the data is. So where is it located in your paper? That's the most important thing, okay? And then keep building the system until you ingrain the system. Ingrain habit. How you do one thing is how you will do everything else. So remember that. If you're messy now, you're gonna be messy later. So for as you can see, I was messy before and I'm still messy. So I can't change that, but you guys can. So try to have a system. So the other thing is number 7 is don't lie. If you do not have data, be honest. It doesn't matter if it's labs, if patients ask you, did you ask them, if your attending or senior asks you, did you ask the patient about this? Did you see their leg or did you see this exam finding? If you didn't, just be honest. Just say I didn't. Trust me. You don't want to be known as someone who's lying. Um, is never good, and it's always better to just say you don't know, and no one's gonna get mad at you. Say you don't know, and then thanks for reminding you, and then you'll go check. You'll check, or say I totally forgot, but I'll make sure that I do that next time. Always be willing to accept your mistakes. That's the most important things. Always do that. Number 8 is if patient looks bad. I'm saying that because for you guys, you're still learning. You're still learning to assess patients, right? Still learning. So if he looks kind of terrible, like maybe he looked better the couple hours before, now something about him doesn't look right. You just bring it up. Tell your seniors. Tell your seniors. Don't wait. Don't wait. Speak up. Okay. Just be like, something about him doesn't sound right. Maybe his heart rate is a little bit elevated. Maybe he has new symptoms that you didn't notice. Just be honest. Okay. Okay. So this is a lot of stuff. Um, does anybody? Okay. So the going back to the question that was posed is, people having issues, sometimes being in the room for too long and time gets cut off. They don't have much time to see other patients. Just be honest with that patient. Just the most important thing that you want to eliminate excess time with patients is to understand why you're going to see that patient. Identify key questions that you want to ask relating to that problem that they have. If they have sepsis, cellulitis, is the skin getting better? If they have pneumonia, are they still coughing up a lung? Are they still having really bad shortness of breath? Are they still feeling fevers and chills? If they're having heart failure, do they still have pitting edema? Do they still have a JVD? Are they still requiring a lot of oxygen? How's their shortness of breath? Are they able to lay flat? Are they coughing at night? All those things. Just be direct, ask pointed questions. You're not, unless they're like, a new patient, you won't really ask them open-ended questions. At this point, you do obviously in the beginning is like, how was your day? How'd you sleep? But you want to be direct with them to be efficient with time. And if they're talking about other things, it's okay to tell them, I really understand that you're concerned about this problem, but I came here this morning to focus on this problem that brought you to the hospital. So is it okay if I ask you these specific questions? And then later I'll come back and I'll listen to this problem that you might have, etc. Obviously, then I have to try to figure out if it's a problem that maybe you should be concerned, maybe listen to them, or you should definitely listen to them if it's a concern for them and it's something that you think is relevant. But if it's something non-medical, then you obviously are able to tell them to get back to the topic at hand. Use your best judgment. Don't piss patients off, but be nice about it. Don't dismiss them. Just be honest with them. If you have other patients to see, just tell them that, and tell them that you'll be back, and make sure that you're actually back. Don't just say that. Okay. Does that answer your question? Okay. So before we go on to the next topic on presentations, is this helpful, or should I speed it up? Um, so what is the difference between pre-rounding and rounding? Okay, good question. Really the big difference between pre-rounding is kind of something we do here in the United States. I'm not sure if you train here or not, but basically pre-rounding is a way for students to learn. is mostly done in residency programs where you give time for the residents to see patients early, have their own time to process the information, come up with assessment plans, management, and then rounding is when everybody gets together and talks about the patients. So during pre-rounds, it's just you, the intern, or the resident seeing patients on their own, and then rounding is when they get together and discuss patients as a group. So that's really what rounding is. So with that being said, rounds. I want you to understand what time does round start. Know exactly where to meet. Be early. Be prepared. And try to see patients always. And if you can't see a patient, it's okay. Just be honest. If you didn't have time to see a patient, especially during your first couple of weeks, things are gonna be crazy. You're still trying to figure out the hospital. You're not gonna be the only one who missed seeing a patient or two. Just again, don't lie. Okay, presentations. Who here thinks that they need to work on their presentations or they feel like they have a good system down? Need work? Okay. Who else? Need work? Okay. For sure need improvement. Oh, I need work. Okay. Yeah, everybody does. Thanks for sharing. So before I move on to long-winded, okay, that's good. So yeah, let me know what you guys find trouble with in your presentations so that I can help you better. And I'm sure the people who are listening might have the same problem. So if there's something that you can remember, when I was a med student, I struggle with this. I want to make sure that we could kind of hammer those details out so that we're able to like intern year day one, like feel confident. Are the patients also visited during rounding, or is it only a discussion between the residents and attendings without visiting the patient? Depends on the team. Some teams like to round with patients at bedside. Others like to do something called table rounds. So it really depends. It could be a mix of both though. So things you need to work on is structure, what to include and what not to include, having a good story and being precise. Okay. And others, it's been a while since you graduated. Okay. No problem. We'll work on that together. So before I do that, the above, the things that we talked about with professionalism, ward schedule, rounds, all these things, did that all make sense for you guys? And did you guys have any questions about that before we move on to presentations? It made sense? Okay, great. Any questions on that? I want to make sure that you guys understood what I said before moving on to the next topic. And if anybody has to leave, can you guys let me know? Um, everybody okay on time? Yes, you'll get on time. Okay. Okay, perfect. All right, great. I'm glad you guys are still enjoying it. So it seems like so far we still have the same amount of people that joined us. So I'm really happy to hear that. Okay, so let's talk about presentations. And thanks again for being honest with where you guys are at. So presentations is, the most important thing is, well, not in any order, but the way that I like to think about presentations is, it's a time for you to really, it's hard, right? It takes time. That's the whole point of the training is that you're gonna get better presentations with time, with pattern recognition of different diagnosis. You're gonna have a better idea of how to present data. But for now, you don't really know what's important, and that's okay. So all you need to know is that you need to collect data. With time, you're going to be able to decipher, okay, this is not important, this is important, this is why it's important. Okay, maybe I shouldn't say this. That's okay with time. But for the most part right now, is as long as you have the data, as long as you have a systematic way of presenting the data, you will still be able to look good with presenting patients, regardless of how much you still have to grow, if that makes sense. Versus someone who is disorganized, they might have all the data, but if they're just organized, it just seems like they don't know anything. They don't know what they're doing. So really, organization is the most important thing. Knowing exactly how to be systematic with presenting is key. So let's start. Let's say pretend your first day on wards. You're meeting with the team. This is you. You're like kind of pissed off because it took a long time to round. Either you're a guy or you're a girl. I don't know. And then and then you have you're attending who's looking at you. So you probably a little bit scared, right? But this is what you need to do to really not look as scared. Is just know your patients. Know patients. Why are they here? So first, the uh, one liner, right? So it's age, right? Name, right? So you guys say the name of the patient. You could say, Miss S, who's a 50-year old or whatever year old, um, female, sex, with past medical history of X, Y, and Z, right? So keep it pertinent. So don't say toe fracture if the patient is not coming in with like something associated with skeletal muscle problems. I mean, hypertension, hyperlipidemia, sure, that's fine. Diabetes, that's fine. Um, you know, if they had other prior admissions for the same thing, you could say uncontrolled COPD, uncontrolled is with prior admissions, et cetera, et cetera. Heart failure, that's important. All these things are important. Um, and then you could say with past medical history of this, now presenting with what are the symptoms? So is it acute, subacute, or chronic? Less than 3 weeks, 3 to 6, or like greater than 6 weeks around there. It's like chronic. Is it a chronic thing that's it's going on for a while, or is it like subacute between 3 and 4 weeks, 3 to 6 weeks, or if it's a chronic thing? Um, so let's say this patient, for instance, so typically you would present it like this if it's an HMP. If it was an HMP that you're presenting, let's say it's a new patient, you'll say their one liner. Basically, you're presenting the patient. So you'll say to the attending, "Hey, this is a new patient. I'll start from the beginning. So this is Miss S, past medical history of hypertension, hyperlipidemia, congestive heart failure with prior admissions for decompensated heart failure. Now presenting with subacute symptoms of shortness of breath for the past 3-4 weeks associated with um, leg edema and weight gain, right? You didn't tell me the diagnosis, but you're kind of telling me the symptoms, and then you talk about the history. So go in detail, like what exactly happened. So like so basically, the best way to I organize history is what was her baseline and how was she doing, and then what happened. You're telling a story to imagine you're telling a story to like your brother, your sister, your younger brother who's not in medicine. You can let us say, yeah, there was this healthy lady who has this history, but she wasn't taking her medications, and all of a sudden her leg starts getting swollen, started gaining weight. Obviously, this is all non-medical terms, but that's how you want to present it in a way, obviously with medical terms, but in a way that makes sense. So really, what happened and how fast did it happen? Okay, so basically, and then associated symptoms. So was there associated symptoms? How fast did it happen? So basically, tell me at the beginning, how was she doing? How soon? How long ago did it happen? Um, and what happened exactly? And how fast did it happen or worsen? Like, did it get better? Did it like was it like her symptoms like just bad? Were they like this bad? Was she like feeling like crap? Got better, then got worse? Or this is like This is bad. This is time. So she just through time she just felt bad, felt okay, and then all of a sudden felt bad. This is more a gradual process. This is more like she was feeling bad initially, then got better, and then now it's really worse. Or or other things, you know? You've This is really what you're trying to figure out. What was her trend? Trend. Try not to be too confused. Either it's better, it got better fast, slow. Don't be too confusing. Don't be like it got better here, then don't be all over the place. I don't. It should have a story. It should be if it makes sense to you, it should make sense to you. If it doesn't make sense to you initially, you want to present something, it probably won't make sense to the attending or anybody else. So associated symptoms, right? It could be anything: fevers, cough, weight gain, shortness of breath, chest pain, nausea, vomiting, diarrhea, um, any headaches, headaches, etc. Basically, any symptoms. You don't have to go through everything. Obviously, if someone who's coming in with like chest pain, you're gonna ask them all everything. You're obviously gonna potentially could ask them about fevers, cough, all these things because you could have endocarditis, right? With chest pain, shortness of breath, chest pain, all these things. You want to just make sure you ask them. You could ask them what are any other symptoms. And the way I like to do it is I asked, was there any other symptoms that you forgot that I forgot to ask you about that you were having, and ask them when they started. What started first? What started first? Then what other symptom did you have? Okay. Then what other symptom? So okay, I think that's kind of how I would do it. Basically, the way I would say is you present a patient, you tell your attending, this is Miss S, 40-year-old patient with a female patient with past medical history of X, Y, and Z, pertinent, right? Pertinent. Not presenting with 3 weeks of. You don't have to say acute, subacute if you don't want. You can just say how long they've been having it with 10 days history of or worsening symptoms of shortness of breath, chest pain, and leg swelling. And you could say, patient was of normal health as of 3 weeks ago. She normally is able to do this, but notice that 3 weeks ago, all of a sudden, she started having weight gain, also orthopnea, and some chest pain. And then you could just kind of go over the details specifically if you want. It, it should flow into a story. Um, and I think that's really where the art of how you communicate information really shines. But the most important thing is that when you're communicating information, you really want to make sure you're thinking, okay, this patient comes in. So what is their concern? What is their chief concern? For instance, shortness of breath. Okay, this is what you think. How do you form a differential? What could be shortness of breath? What could be related to shortness of breath? Multiple things, right? Oh, could this be a PE? Okay, yeah. Could this be a acute coronary syndrome? Yeah. Can this be musculoskeletal? Okay, yeah, it can possibly. Um, can this be a pneumonia? Pneumonia. I'm terrible at writing. All right. So form a differential, pneumonia, right? um, can this be trauma induced? Pneumothorax. Can this be heart failure? Can this be you could think ascites causing low tidal volume, patients not able to breathe well. Multiple different things. Form a differential, um, you know, and eliminate things. You're gonna have to, this is something that you will do the more experience you get. But you have to ask yourself what you want to learn pattern recognition as you get more experience with your training. It's gonna come with pattern recognition. You're gonna be like, okay, P, cool. So P, patients have risk factors, right? Virchow's triad, right? They have they have some form of stasis, some injury, some immobility, right? So do the patients have that kind of thing? Okay, maybe they don't, but sometimes you could have P without really any of these risk factors. Do they look like they have a P? Okay, are they having tachycardia? Are they having tachycardia? Okay, maybe they're not. Are they requiring oxygen hypoxic? Okay, yeah, sure, but all the other ones can too. Okay, are the asymmetrical uh, leg swelling? Okay, sure, maybe they have a DVT. Okay, are they hypotensive? Oh wow, maybe they do have like some shock, right? Maybe they're in shock from PE, an obstructive shock. So this is basically like higher level principle of thinking, but I want you to get to that level, and it's only going to take time. You'll get there before you know it, honestly. But that's the whole point of when you're presenting HMP is to think about it. So you could say, let's say you thought about all these things, right? And they'll come into your assessment and plan later. But when you're talking about associated symptoms, let's say they have all these symptoms. You say patient with associated symptoms of X, Y, and Z, but you could also say denies recent travel, fevers, sick contacts, sick contacts, etc. Right? So that's really kind of what the point is, for you to have an idea of how to present data. And the only way to really have an idea is to form a differential before you even, like, when you see the patient, when you're collecting history. If you someone coming with chest pain, form a differential. Google it, go to UpToDate and be like, what is the differential of chest pain? Okay, it could be multiple things. You ask these questions. Are you having this? Are you having that? Are you having that? Oh, no, no, no. Then you're like, oh wow, okay, they have fevers. Okay, can this be a pneumonia? Oh, did we get a chest X-ray? We didn't. Let's get a chest X-ray. Okay, so forth and so on. Hopefully that makes sense. Does that make sense for everybody? This is really simple stuff, and I don't know if it's simple. It did. It wasn't simple for me when I started, but maybe it's simple for you guys. Okay, cool. All right, so that's how you present like the beginning stuff. That's just the HMP, right? So to review, you have your one liner. Okay, so you're saying if it's a new patient, you talk about the symptoms. So if it's a new patient, you say X, Y, and Z with past medical history presenting with symptoms, I would say, and then you talk about the history, physical, right, which is above what I told you. You talk about the ED, how when they presented to the ED, how were their vitals, how were their labs, right? What was their management in the ED, okay? And then overnight events, and then now you go into SOAP. Does that make sense? Versus if it's like a old patient, meaning like a patient, um, I'll say prior, it's probably better. Prior patient, you've had the attending already knows. Same idea, one liner, except instead of symptoms, you're gonna say you can say the whole thing, history of this with past medical history of this, presented with symptom. You could say either consistent, concerning, um, presenting with symptoms concerning for the diagnosis, whatever diagnosis, or in setting, if you feel like it's pretty slam dunk that this is the diagnosis. So for instance, someone coming in with decompensated heart failure, you could say shortness of breath in setting of decompensated heart failure, because you probably already got an echo that maybe showed it, or they had a lot of clinical evidence for it. You don't diagnose heart failure with an echo, but clinical features, right? So maybe they had really strong clinical features to suggest they're in decompensated heart failure. Does that part make sense? Okay. So then the other thing would be obviously we talked about the SOAP note. Um, so just have it organized, like I mentioned. So really the biggest thing that I was going to say, I know that some people are, we've been here for an hour already. Do you guys want to continue for the next couple minutes, or should we leave it off here and finish the rest, forming differentials, the plan, interpreting labs, x-rays, EKG, fluids, antibiotics? I'm not going to finish all of it today, actually, but I was going to continue a little bit more. But I could stop here if you guys want to take a break and just maybe come back tomorrow. Let me know what you guys think. Or instead of either works, okay. So how about we, because the next part was going to be, I want to give you guys a break. I don't want to give you too much info. So how about we spend the next 5 minutes, 5, 10 minutes answering questions? Anything goes. Tomorrow, we're going to continue on forming differential diagnosis. So just kind of let your mind rest a little bit. Um, Perfect plan. Okay, great. Yeah, it's a lot of info. So tomorrow, I'm going to talk about forming differential diagnosis. This is where you shine, really the most important thing. We're going to talk about how to work up patients. I'm going to give you some examples that we can work together. Interpreting labs, Chem7s, CBCs, interpreting x-rays, interpreting EKGs, fluids, antibiotics, all these things. So tomorrow will be also a big day. So I think we spent an hour and 20 minutes already. How about we answer questions that you guys have of the things that we talked about today? Number one is like, is this useful for you guys? Do you feel like you're getting some, do you feel like this is beneficial? And has anybody actually seen online med ed? And like, I've seen a video, I've seen like a couple videos. I'm not sure if it's that helpful, but have you guys seen online med ed, or do you guys even know what that is? Thanks for those who commented. Is it the same? Is it the same time tomorrow? Yeah, I think it'll be the same time at 2 p.m. I'll send you guys a link again. What is short call? Short call is basically where you're not admitting past like 5 typically. Short call, you might be done at 5. Sometimes if you're on long call, you're finishing at 7. You're admitting till 7. Short call, you stop admitting at 5. So you're able to leave at 5. And it usually it's every other day that you're on short call. Austin, paid for online med ed, intern boot camp, but the tips weren't too practical. Okay. Do you feel like what the info that I'm giving you here, do you feel like this is more practical? And what feedback would you give me for those who have been here? Yeah, online med ed is very superficial, I think. I don't know. I wanted to make something better. So hopefully this is better. Well, it's probably too early to tell because I still haven't finished the course. Okay, thank you. I'm gonna come back tomorrow again, okay? So tomorrow we'll continue on. I don't want to give you too much info. And so tomorrow we'll get started. We'll do another hour session. So for those who have to leave, that's okay. You're not gonna miss anything. I'm recording this anyways. I'm just gonna stand here to answer any questions that some people might have. How much how much is physical exam expected on every patient? Adding pertinent parts as necessary. Sometimes the templates have a lot of things. I don't know if I need to fully check on every patient. No, you don't. You just gotta check obviously grossly how their cranial nerves are. Like just look at them. Are they talking fine? Are they moving their extremities? All those things. If it's a neural patient, then obviously you might have to do more of a detailed exam. Pertinent labs, pertinent physical findings. I listen to the lungs. Sorry, the lungs. You can listen to it here too. But their cardiac exam. I press on their stomach. I don't oscillate always. I look at their legs if they have any edema. Exam itself shouldn't take you that long. Less than a minute. Hope that helped. Okay. So I know we have some extra time. Um, my physical exam skills are poor. How much is expected from interns in regards to doing physical exams? You should be able to do the basics. Also take. You don't have to. You have to just identify murmur. If you see a murmur, you don't have to know exactly what kind of murmur it is. You'll get better with time. Identify how the lungs sound. If it's clear, crackles, you'll take some time to really fully understand how to hear that. You basically have to just feel if it's coarse. Coarse breath sounds is really a good go-to word for physical exam findings. Uh, but it's also expected, right? Look at if they're coming in with heart failure and you say it's clear and yet they're requiring a lot of oxygen. Maybe you didn't do a good exam and you should go back and check. So kind of use the other data you have to try to figure out what should I be listening to or what should I expect to listen to if this patient's on a bunch of oxygen and their x-ray looks like they're congested. Maybe they do have some weird lung sounds, right? But it's not expected for you to know everything. It's going to take time. Um, Hope that helped. So, obviously, we already. Any other suggestions on what to talk about tomorrow? Since I'm finishing this up, I want to finish the rest of what I planned on doing tomorrow, which was spending more time on differentials, plants, interpreting labs, interpreting X-rays, EKGs, fluids, antibiotics, a little bit of night flow, cross cover stuff, pages. Was there anything that you guys can think of in terms of floor wards type thing that you feel like I should cover? Maybe sugars, right? Like diabetes stuff. Sugars. Okay, I could do that. I'm adding that in. So you could talk about diabetes, like inpatient glucose management. Oh, electrolytes. I like that. How could I forget? I haven't repeated electrolytes in years. So so thanks for reminding me. Electrolytes. Let's do that. Yeah, I have to cover electrolytes. Admitting patients. Okay. Admitting patients. Like orders, right? Like orders. Okay. Especially sodium. Okay. Acid base. Yeah, acid base will be talked about in the Chem 7 part. Pagers. Okay. Relationship builders. Okay. Pagers and how to and their use. Okay. What to expect and what to expect. Yeah. Page. I'll cover that for sure. Cool. So I'll talk about what you guys said. Glucose management, electrolytes. Oh, consults. I was gonna talk about how to call a consult. How to call consults so you don't get screamed at. So I forgot to tell you guys who are there's only 40 people here. I just had a kid. I'm a dad. I became a dad a month ago. So if you guys are parents, it's tough. You guys can do it. Residency is gonna be hard. Oh, thanks, man. Man, I love doing this. I just want to thank you all for taking a chance on me and really trying to learn from me. I think that's an amazing thing that you guys are so willing to listen to other people. And I hope I could give you guys like the time that you're spending and it's gonna be worth it. Um, so thank you. I am also, sacrificing time away from my kid, which of course it's something that I want to do because I love doing this. But I wanted to just let you guys know that part. Mostly just to let you guys know that if you guys are parents or think of having kids, it's okay to do it. Don't let residency life stop you. You're always going to be busy. There's never going to be a perfect time to start a family. So if your partner has thought about having a family and you feel it's up to you. If you feel like you want to wait till after intern year, that's also fine. Um, but I think it's the best thing that's ever happened to me. It's difficult sometimes not sleeping much. So hopefully today I didn't sound too tired, and if I did, I'll try to get more rest. So I wanted to be transparent with you guys. So I just want to be honest with you guys what's going on with my life, and if there's certain things that I can't make it or if it's super last minute, there's no excuses, but there's a reason for that. So my plan in the next coming sessions tomorrow, we're gonna finish the awards block. I probably won't have time to do ICU until the following week. I am working in the ICU this week coming up for 6 days straight, and then I'm off on Sunday. So maybe I'll do an hour of ICU stuff, and then a couple more things here and there. Essentially, I want to get at least 5 hours of video of free content, and then with your feedback, I'll make more premium stuff. Which, if you guys reached out to me, I'll give it to you guys for free because you guys are part of this cohort of like giving me info, and I want to do that for you guys. But I want to make a product in which like people are able to like, pay for it and get their money's worth. Number one, eventually I want to scale a company in which I'm not doing all the teaching. I'm providing this opportunity to give some money, but I'm gonna also hire like cardiologists, other pulmonologists, nephrologists, fellows, residents to give an opportunity for them to teach, get money, and teach other people. Because residency there's not much opportunities to really have a stable job outside of medicine. You really can't. You don't have much time. But a lot of us teach on our free time. So why not have opportunities to get paid for it? So my goal is to scale it into an opportunity where with your membership, you'll have access to a bunch of different videos with specialists with cardiology and learning from the best. Um, and obviously the intern bootcamp is the primary catalyst for this, but that's kind of where I see this program, medical online learning growing. And hopefully, when you guys are, hopefully this program or this business becomes big enough where if you guys are interested, it's the second years, you'll have opportunities to teach run a boot camp also. It's something that I definitely want to do every year. Okay. Anyways, guys, I won't keep you guys here for too long. I want to thank you all for joining me and amazing discussions, questions that you had. Just overall, like very ecstatic with your interest, and thank you for making the time to come here. Um, Again, I'll tomorrow. Yeah, what time tomorrow? Um, Quick question. I was thinking of 2 p.m. Is there a better time for you guys? 2 p.m. Pacific Standard Time. Does the same time work fine, or should I do a different time? That's fine. Okay, a bit earlier. Uh, I'll have to see what we're planning tomorrow, Irvin. But we'll see. Whatever works for you. I think I'm probably gonna do it at the same time. But if I do it earlier, it seems like everybody's okay with that too. So I'll have to just figure out what I'm doing. Okay, if not earlier, same time is fine. Okay, I'll try to do it earlier, but if I can't promise anything. Anyways, guys, it's Saturday. Why are you all here? Go out there and enjoy your day. Make sure you guys play video games, work out, go out with family. Enjoy your time before residency starts. I'll see you guys again tomorrow. Have a good day. Get some rest. Thanks again. See ya. See you tomorrow. Thank you guys. I'm gonna stop recording now. Okay.